Hello everybody. I'm sorry about the slight delay. We're having a couple of technical issues in the back end today for some reason. So we're working very hard to resolve those. So thank you very much for your patience. We do appreciate it, and we appreciate you joining us this afternoon for our session. I'm just waiting to make sure that all the relevant people are able to join. So we'll give those a couple of moments. And I would, like I say, welcome to the session. Thank you very much for bearing with us and for joining us this afternoon. We are delighted to have you with us. A little bit about ISSUP. We are a membership organisation who currently have over 16,000 members, and we're delighted that around 4,000 of those are from Africa. So we really feel a strong representation from the region. And we are here to really bring together and support anybody who is working in this field. And by anyone, we really do mean parents, volunteers, those that are just starting out as students perhaps, all the way through to people that are extremely knowledgeable, experienced, working in very well embedded in this field. So we like to bring all of these range of the community together from the prevention, treatment and recovery fields. The way that we work is really, as I say, the mission to have a connected, trained, knowledgeable and effective international network of substance use prevention, treatment and recovery professionals who are out there undertaking and promoting high quality, evidence-based and ethical practice and research. We do this in 3 ways. We work digitally, which is our website. We have links on there. We have networks on there that people can talk to each other. We have information on what's happening in different countries around the world. We also have an extensive social media presence and email newsletters. So we really do work at a global level online to try and support the workforce. Then we have our national chapters who are delivering our mission in country, and they're able to then do that in a more local context, responding to the needs and supporting the workforce within that country. And we have our events, which we used to have in person, and we are now holding mostly online, and look forward to perhaps having a hybrid as we move forward in the world. But we have events such as this one today that really allow us to connect and deliver directly to you. Today I'm very privileged to be opening this session. We do have a moderator who I think we are still having trouble connecting with us. So I'm just going to continue straight onto the first speaker. And it is my pleasure to introduce Professor Obot, who is the founding director at the Centre for Research and Information on Substance Abuse in Nigeria. He's held positions as head of the Department of Psychology at the University of Uyo in Nigeria. He's a professor of public health and the chair of the Department of Behavioral Sciences at the Morgan State School of Public Health in Baltimore, USA. And he's a scientist in the Department of Mental Health and Substance Abuse at the World Health Organization, as well as being a research fellow in drug dependence at the Johns Hopkins University. So he really has some very important roles at the moment, but also a significant academic background, publishing many papers and holding numerous roles for international organizations as well as academic institutions. So Professor Obot, if you'd like to turn on your camera and your microphone. Whilst we're hearing from the speakers today, if you have any questions, please pop those in the questions box and we'll be going through those and collating them so that at the end we can ask those of the speakers. And also be reassured that this recording, as well as the, hopefully the presentations, will be available on the ISSUP website after the session in the next few days. So Professor Obot, are you able to begin your presentation?
Yes, one moment. Can you see anything?
We can see your screen. We still can't see you.
Can you see me now?
Not just yet. Sometimes it takes a couple of moments. Your presentation is great, all lined up, ready to go. We just need your webcam on if possible, please. There we go. Wonderful. Your presentation is now disappeared, so if you're able to, there we go. Thank you very much.
All right. Thank you, Joanna, and thanks for the introduction. And I want to point out that those positions you read out are not positions I'm holding. All of them at the present. Some of them are past things I did in the past. Thank you very much for the introduction, and welcome everybody to this presentation. I'm going to try to take us through some issues around epidemiology on drugs in Africa. This is the presentation outline. So I want us to all understand what we mean by epidemiology, talk a little bit about the prevalence of drug use in Africa, a little bit about alcohol, something that we sometimes forget about, even though it's a big problem in the continent. And then briefly about the epidemiology network that is run by the African Union Commission, some challenges and opportunities, and then conclusion. I think we all know that we have issues, problems with the lack of relevant data on current drug problems in Africa. Academic research in the field started actually quite a number of years back in the late 1950s. So it's more than 60 years that Africans in different countries, Nigeria, Ghana, South Africa, started studying the problem. But we're still having a problem now that we don't have enough data, especially data that is relevant to policy and to interventions. But the good news is that academic research is growing, at least in some countries. I think that has been aided by the publication since 2000 of the African Journal of Drug and Alcohol Studies. As you will hear later in the session, there are epidemiologic data networks that are being developed across the continent. There is the West African Network. There is the African Union Network, which I will talk about a little bit later. And of course, there are some national efforts, which was started by South Africa many years ago. You will be hearing about that later. There is also a national effort in Nigeria. We need all this information from various sources, from the epidemiology networks, from academic research, to guide the development and implementation of effective prevention, treatment, and also to guide policy in different countries across the continent. When we say epidemiology, what do we really mean? Many of us, I'm sure, understand what epidemiology is. From one of the classic definitions, epidemiology is the study of the distribution and determinants of health-related states in a population and the application of the findings to the control of health problems. Epidemiological research is used to describe the health status of populations. It is used to explore the social determinants of health, and it is used to evaluate the effectiveness of health services. There are different ways we collect data in epidemiology. I'm not going to spend time on this. I think many of us, most of us, if not all of us, are familiar with these kinds of methods in research. General population surveys, we don't have many of those in Africa. I'm going to give one example later, a major survey that was conducted in Nigeria. We are all familiar with school surveys, surveys in special populations, and so forth. And then, of course, the background for the analysis of available data, which is what is being done in the network that I talked about, I mentioned earlier. What types of data are we interested in when we do epidemiology? Several types of data, but more important, how much of the problem exists in the case of substance abuse, how many people are using a drug, what types of drug are they using, how are they using? These are questions we ask. And of course, we also want to know the determinants of use, misuse, abuse, or determinants of substance use disorders. And that is answering the question, why? And more important, and increasingly so, we want to know the consequences, the effects of use, effects on health, effects on social welfare, and then we can determine what is going on in the health sector from the demand for treatment. And also we are interested in law enforcement and traffic enforcement issues. This slide is based on data from the World Drug Report 2020. Many of us over the years have depended on this source to know about the epidemiology of drug use in African countries, in different regions in Africa. And as you can see, there are quite a number of empty cells. That's part of the problem that we don't know. For example, in East Africa, the proportion of people, the percentage of people who are using cannabis or any of the other drugs, because the data was not reported to the UNODC. And if you know, this is data that is supplied by member states, by countries to the UNODC, and is used to produce this report. So what we can see, at least from this slide, is that cannabis is used in West Africa and Central Africa more than any other part of Africa. And if you compare to the global average, to the global prevalence, it's almost about 3 times that. This has been a consistent finding over the years. One of the things that sticks out is the opioids. Opioids, the prevalence of opioid abuse has crossed 1% now. As you can see, used to be under that for many years. In short, non-medical use of drugs generally has become a major health concern in Africa, especially in West, Central, and North Africa. We have data from treatment centers, as you will hear later, in West Africa, in North Africa, and in other parts of Africa. I'd like to present an example of what I mentioned earlier of national population surveys, which is highly recommended. It's expensive, but every country needs to do this, not once, something that could be happening maybe once every 4 years, maybe once every 5 years. This is information from the most recent survey conducted in Nigeria, a big survey, national survey, consisting of 3 studies actually: household survey, national survey of problem drug use, and also key informant survey. Covered the whole country, was funded by the European Union. If you look at the quick data presentation here, if you look at the prevalence of drug use in Nigeria, 14.4% of the population, 15 to 64-year-olds, had used a drug in the previous year. I'm talking about the illicit drugs and pharmaceutical opioids, for example, and other pharmaceutical substances. It does not, of course, include alcohol, which I like to emphasize is a drug. So 1 of 4 of the users is a woman, which is 25% of the population reporting drug use. Now, what types of drugs are they using? As you would expect, cannabis came on top with 10.6 million users in the past year, 4.6 million opioid users in the past year, 2.4 reporting the use of cough syrups, and so forth. So this was the first opportunity in Nigeria to get this kind of information, and it has been very influential. Taking another look at the data, this is data on age, a quick look at age, and if you can see, people 25 to 39 are more likely to have used drug in the past year than other age group, and the drug again is mostly cannabis. One interesting finding in age is the use of pharmaceutical opioids in the older age group more than any other age group. I said I'll mention something about alcohol, just one slide. What we know about alcohol use in Africa is that most people in Africa do not drink compared to the rest of the world. There are more abstinence in Africa. But what we see is that if you look at those who drink, the per capita consumption is much higher than in the rest of the world, 40 grams per day. That's about 4 drinks per day. Heavy episodic drinking, that is drinking maybe 5 or more drinks at a sitting, is higher in Africa than the rest of the world. And of course, it is not surprising, therefore, that alcohol attributable deaths is higher in Africa than in the rest of the world. Now, let me say something about the Pan-African Epidemiology Network on Drug Use. This is a program of the African Union Commission. It was launched in 2016 with the recommendation of ministers in charge of drug control, because everybody was concerned about the lack of baseline data and information on drug use. And this was seen as a hindrance to program development. So in 2016, the AU Commission launched this surveillance system and asked countries to join. As at present, more than 30 countries are participating in the network, and these are the countries joining at different times. What has been the progress up to date? Well, as I said, a national drug surveillance network has been established in each of about 30 countries out of the 55 AU member states. The inaugural report of the network was launched in 2018, reporting on data for 2016 and 2017. The second report will be released soon. What the effect has been that there's been some improvement in the availability and quality of data in different countries in the continent, so that countries are using the information from the network that have been established in the country to fulfill international reporting obligation. For example, supplying data to the UNODC or supplying data information to the INCB. So I can take a quick look at some of the findings of the Pan-African Epidemiology Network on Drug Use. In 2017, the number of facilities that reported ranged from just about 1 in Guinea to about 83 in South Africa, meaning that there is a wide range of number of facilities reporting in different countries. Following from that, The treatment episodes reported how many people showed up in the facility each year range from about 180 to quite a very high number in South Africa. Not surprising, the primary drug responsible for treatment seeking was cannabis or alcohol. The types of people reporting to the facilities were young adults between the ages of 15 and 34 years. The majority of them were people who had completed secondary school, they were unemployed, and they lived in urban areas. We noticed that the average age for entry into treatment for alcohol was higher than for cannabis dependence. There was little information about seizures for cannabis and cocaine, even though most of the countries reported. Relatively few countries report seizures of heroin and other drugs. There are a number of issues, of course, with this project, with this program. It's a new program, so it's developing. So there are a number of constraints for the program and also for epidemiology research generally in Africa. Lack of data, funding issues, governance issues, and a number of other problems, personnel, human resources issues, and of course, definitional issues whereby one term means the same thing to everybody in all the countries. We have issues in the program with reporting from civil society organizations. Many of the facilities involved in the project are run by CSOs, by NGOs, and sometimes it's a problem of getting data from these sources. And then, of course, the program is highly urban-based. We don't have information from the rural areas. But there are opportunities. There are some positive aspects of the project. We now have information. Epidemiology information has been used to spark national debate on drugs in some parts of the country. Record keeping is improving in some countries. Countries have the opportunity to use the framework that has been developed to replicate this kind of work in different parts of the country and so forth. But I think very important is that policymakers have a source of information about drugs in the country when needed, especially in the development of policy in the reform of drug laws. We have a problem, as I said at the beginning, of data in Africa. Epidemiology is a young field in the continent, but it is growing, as I said, in academic settings and also in the development of the epidemiology networks. What we know from available data from a limited number of studies is that drug use disorders are increasing and they are associated with public health problems in different parts of the continent. I think we all would agree that there is urgent need for regular data from population surveys, from the epidemiology network, and from other methods of data collection to inform the prevention, treatment of drug problems, and also to guide in the development of policy. Thank you.
Thank you very much, Professor Obot. That was an excellent in-depth presentation. It's much appreciated. So we are still having some problems with connection, so we're going to move on to our next speaker, who is Dr. Nadine Harker Burnhams. And she is a specialist scientist in the Alcohol, Tobacco and Other Drug Research Unit at the South African Medical Research Council. She currently holds the position of Honorary Research Associate at the University of Cape Town School of Public Health and Family Medicine. She's worked in many academic settings, publishing research and teaching, as well as co-authoring a book titled Alcohol, Drugs and Employment. She has advised local, provincial and national government, as well as the UN, on issues related to alcohol and drug abuse prevention and policy. So it's my pleasure now to hand over to you, Nadine. If you could turn your microphone and camera on, and Professor Obot will say thank you. If you could turn your camera and microphone off. Thank you.
Are you able to see my screen?
We are, thank you.
Okay, just want to move something around. Slideshow. Here we go. Thank you, Joanna, and greetings to everyone from South Africa. As mentioned, I'm Nadine Harker, and I work for the South African Medical Research Council, and I head the South African Community Epidemiology Network on Drug Use. This is just the team that works with me, and below you'll see all the collaborators on the SACENDU network, which we always acknowledge and give thanks for all their data that is always available to us to use. Just in terms of content and what I will be speaking about, it's just SACENDU, which I did indicate stands for the South African Community Epidemiology Network on Drug Use. Some background on objectives, methods, and then just some trends that we've been observing over the last 11 years, and to also share with you some additional data that we have started entering into, and as or organizations that have become part of the SACENDU network, which supply us with information on persons with injection drug use, persons who use drugs, and OST. And these are collected from community outreach services. And then I just thought to share some work that we've done around COVID-19 and future work. Nothing extensive, but just some insights. Perhaps we'll be sharing some implications for policy practices, limitations, challenges we have had, and then of course the conclusion. So SACENDU is an alcohol and other drug sentinel surveillance system operational in all 9 provinces in South Africa. We monitor trends in alcohol and other drug use and associated consequences on a 6-monthly basis. Normally that would be from January to June of every year, and then again from July to December from specialist alcohol and drug treatment programs, and that's where SACENDU initially started. Back in 1996, it modeled after the drug surveillance systems established by the Pompidou Group in Europe, and of course the US Community Epidemiology Work Group. But I've mentioned that we collect treatment data, and more recently we have now included data from community-based harm reduction and health services to expand on the data that we have and give a better reflection of the situation, the epidemiological network situation within our specific country. We have also started looking at hospital admission data, which we haven't collected before, and this is in partnership with the Department of Health in one of the provinces, which we call KZN or KwaZulu-Natal, although this is only commencing in 2021. but it just gives an indication of where we are heading. SACENDU was initially funded by the World Health Organization, but now it's funded by the National Department of Health and more recently the Department of Social Development. Our objectives is to identify changes in the nature and extent of alcohol and drug use and emerging problems, identify changes in alcohol and other drug-related negative consequences, inform policy planning and advocacy, and this is absolutely essential. SACENDU is very often used within government departments to help inform policy issues and planning issues for government. To support networks of local role players in the substance use area, to stimulate new research, which is key, and also to facilitate South Africa's full participation in international fora. So we provide data, as Professor Obot mentioned, to the AU as well as to the UNODC around the ARQ, which is an annual process that we go through. So I thought to just briefly speak about our data sources and limitations, what we have and what we don't have. I think our ideal would be to have a central data collection system, but we've had our own limitations within the country. So the green is really research that does happen, but does not happen annually or every 5 years. It's sporadic at times. So we have had youth risk behavior surveys, although the last was conducted in 2011, and then various surveys since then. But I think the important point to stress there is that there are no household surveys dedicated to alcohol and other drug use for South Africa, and this is certainly a limitation for our country. And we have a lot of community provincial type surveys happening, rapid assessment, intervention research, either confined to local areas or provinces. What we do have currently is the blue bars, which is treatment demand data, and that emerges directly from SACENDU and the people within people with injection drug use, and that is data that we collect and are given through community-based harm reduction and health services provided by a range of organizations around South Africa. Ideally, we'd want hospital data, psychiatric hospital data. Where we fit in now is we are trying to start and kickstart this off in one province and see how it goes. We have although this data is available, we are still trying to gain access to customs and mortality, mortuary data, forensic data, and try and set up an early warning system. So how does SACENDU operate? SACENDU is voluntary membership. Any treatment center, any academic, any general individual interested in substance use can join SACENDU. We meet biannually to present, discuss meaning and implications of data from different sources. And for now, our main data sources are treatment episodes and then harm reduction data. And as I alluded to earlier, we'll be looking at hospital data, which would include psychiatric hospital data. In the past, we've had access to data from the South African Police Services around arrests and seizures, and I've alluded to household and school surveys that have happened, but these are all on an ad hoc basis. SACENDU is operational in 9 provinces, and as you can see from the map over there, a lot of our treatment centers are concentrated in certain heavily urbanized to the Western Cape, but the Cape Town area. If you look north of the map, the Gauteng area, which is your Johannesburg areas, and then the poorer provinces, which is to the right, below. You can see those are huge provinces. The Northern Cape is also to the left top, huge provinces with minimal resources as far as it pertains to treatment facilities. KwaZulu-Natal is also quite well represented when it comes to treatment centers. Currently, we have 86 treatment centers nationally that are part of our network, and they cover approximately 80% of our treatment population and 75% of treatment centers. They include both state-funded, private, and non-governmental. And on average, we see in a 6-month period around 9,804, and that was just 2019 B, which is July to December of last year. And as you can see, provinces such as the Eastern Cape only have 5 treatment centers. Gauteng and Western Cape are really lead in terms of access and availability of treatment. So the biannual process really, in essence, just works with people that present at treatment centers. Data is collected on them. And we have regional reps in each of the province that facilitates this and sends us the data. Data is collected throughout the year and captured and analyzed by the MRC, by colleagues that I've shown you pictures of them earlier. And then we present the data biannually, and this is normally around April or October. In fact, our SACENDU webinar commences tomorrow. We also invite speakers from research institutions that have done work in the province that we are presenting the data at. And this is an opportunity to share new research with treatment providers, with other academics, so that provinces are kept abreast of what is happening in their region. They also have the opportunity to share if there have been new trends or something that they've noticed or observed. So just in terms of data collection for treatment demand, we have a standardized one-page form which is given to treatment centers, and each person that presents for treatment would complete such a form, and that is just an outline of what we collect. We do collect data on HIV testing in the past 12 months, given the concerns around HIV in our country, and we also collect some data on NCDs and the use of codeine. For the community-based harm reduction services, through our liaison and collaboration with the institutions that I've mentioned earlier, such as TB HIV Care, ANOVA, Outwell being the Foundation for Professional Development, Tinswala and the University of Pretoria's Department of Family Medicine. From them, we get data on HIV testing and TB prevention, testing and linkage to care, harm reduction, behavior change interventions, needle and exchange services, opioid substitution therapy, monitoring of human rights, and other referral for treatments services, routine hepatitis B and C testing, diagnostic and treatment services related to that, although there are limitations sometimes in some of these areas around this. The second part of the data collection is, which I also just alluded to earlier, is hospital admission. We have a separate form, SACENDU form, that we've designed recently in collaboration with the Department of Health in KZN, and we will start collecting data from them, from psychiatric facilities, community health centers, general hospitals, accidents and emergency centers, and that would be on demographics, past 12-month HIV testing, previous treatment, mental and physical comorbidities, symptoms at admission, alcohol, tobacco and other drug use, and treatment provided, and referrals if there were. So just to share with you, and I think Prof. Obot already mentioned some of this, so I'm not going to labor on these slides, but just to say that certainly Africa has a problem with alcohol. South Africa also, we have a lot of people that abstain from alcohol, but of those that drink, they drink quite heavily, and mostly over weekends, interestingly. So this is just the proportion of persons in treatment with alcohol as their primary substance of use. If you look at some of the data, we've seen really less people seeking treatment for alcohol use over time, specifically in our central region, which combines 2 provinces, and in our KZN region. But when we look at some of the other slides, some of this can possibly be explained. So this relates to cannabis, and this is people seeking treatment for cannabis as their primary substance of use. And certainly in the northern region, which is your yellow, your orangey line, and then the central region, your light blue, and KZN, they generally lead with persons, or the proportions of per person seeking treatment. And we have found that some of this cannabis could possibly be aligned to heroin use, in that in the country, people are using something that is locally known as nayopi, which is in essence really heroin, cheap heroin mixed with cannabis, and marketed amongst young people. It is cheaper than heroin, and has become quite problematic in the northern region and the central region, which are some of the poorly resourced regions or provinces in our country. And we have highlighted and flagged that as a concern. We have provincial variations when it comes to primary and substances of use. So we find that whilst this nayopi or heroin mixed with cheap cannabis is quite dominant in the northern regions and the central regions, in the Western Cape, where Cape Town is, methamphetamine is the drug of choice really. And if you look at the middle graph, that's where methamphetamine is the primary substance of use, and 30% of people that come in have methamphetamine as their primary substance of use. If you combine primary and secondary together overall, which is your green, it is in the area of about 43% of patients would indicate that they have methamphetamine as a primary or secondary substance of use. Oh my goodness. Okay. So across regions, if we look at this slide, between 24% to 30% of patients under the age of 20 access treatment services. And this is has been the case for a while now, except with a slight dip for the region in 2018B. KZN reports the highest amount of admissions for persons under the age of 20, which is really a concern and has implications for prevention and treatment. We've recently published a paper on injection drug use. I'm happy to send it to whoever needs it. Between 2012 and 2017, which looked at opioid use in South Africa specifically. And just in terms of injection drug use, I thought just to show you this slide, which was a trend analysis that we did, and we found a small but statistically significant increase in the overall proportion of patients reporting drug use between 2013 and 2017. In respect and in relation to polydrug use, between 2009 and 2019, we've seen an increase in the number of patients using more than two or more drugs of abuse, and those are per region. So just as a country as a whole, as we stand in 2019B, primary and secondary drugs from all 9 provinces, we find that 44.1% of all patients report cannabis as a primary or secondary substance of use, followed by heroin, and then followed by alcohol, and then methamphetamine. Some data on our community-based harm reduction services. The data we get from NACOSA, TB, HIV care, and all those listed there. It's provided and collated by Dr. Andrew Scheibe and then sent to us. So just some highlights from data from TB HIV Care, TB HIV Care Step Up project. So in January and March 2019, 1,566 persons with injection drug use access the services, and the breakdown, if you want to hone into that, is over there. And between April and June, 1,592 people with injection drug use access services across these sites. These are people that do not go to our traditional treatment services, which I spoke about and I shared data. These are patients that seek services from places like TB, HIV care, etc. So, and across their sites, 98% were over the age of 20 years, and the majority were men. TB HIV Care also provides needle and syringe services, and 8,392 needle and syringe service contacts with people with injection drug use were made in this time period last year. And of the needles and syringes that were distributed in last year, the last reporting period, the return rates for these were 68% and 74% respectively for the two areas. They also provide HIV testing, and in the period under review, which was last year, 440 tested for HIV, and 11% of whom tested positive. 8 of their clients were started on antiretroviral treatment, and 522 persons with who use drugs were also screened for tuberculosis. And I've just put the regional data in there for you because I know the slides will be shared, and if you want to engage with it further. Just in terms of that's a table also provided around opioid substitution therapy, loss to follow up. Also some information just for you to have a look at. My time is almost up, so I'm just going to quickly flesh through all of this. From ANOVA, which is also up in the city of Johannesburg, January to June last year, 1,518 unique PWID persons with injection drug use access services. And then again, Out Wellbeing also works with people who inject drugs, and again, needle and exchange needles and syringes were distributed with a return rate of 88%. Again, HIV testing is also a service that is offered, and we record and we get the data in relation to that. So I'm going to skip these last slides, but that is a PowerPoint presentation for you to look at. The city of Tshwane, which is up in the north, did do a household survey, and what they found emerging from their data, and those are the households, 10,489, they found that alcohol, cannabis, and heroin were the commonly reported substances that were used. So just in terms of COVID-19 and alcohol, what we found is South Africa is one of the countries that went into strict level 5 and 4, and during that time they banned the sale of alcohol, level 5, level 4, and slightly opened their restrictions around level 3 and 2 again. But since the lockdown, since level 5 and 4 with a ban, approximately 2/3 of trauma cases disappeared, including an estimated 9,000 alcohol-related admissions. And this was work done by Perry and Mitsopoulos, and I thought that it's important just to share that as a lot of policy work emerged out of this and was sent through. Other studies underway at the moment are surveys related to COVID-19, as well as a SACENDU survey that we are currently finalizing and writing the data up for, which monitored treatment need during COVID-19. So I'm going to skip that because it's something that you can perhaps read and engage with afterwards. but perhaps just some general limitation and challenges around SACENDU, which continues and prevails, is always ensuring participation. I mean, we've done great in getting ANOVAs and the TB HIV cares on board now, which gives us an opportunity to have a data collection system, which is more reflective of what is happening in the country. Very often, because it's a voluntary system, there are staff changes and treatment centers drop out. Or there's financial constraints. One of the other issues is differential access to services based on socioeconomic status and the limited availability of treatment service for marginalized groups. And as I mentioned, some provinces are really affected by this. It's difficult to determine the extent to which findings reported in SACENDU can be extrapolated to the general population, but we are trying to work towards this. I think most countries have funding challenges related to this. We are no exception. And there's sometimes difficulty in accessing ongoing data from sources other than the treatment centers, but it's a work in progress, and we're enthusiastic and quite happy to keep trying. If you want any information, there's our website and my email address. As you can see, we have 3 reports that emerge biannually from this work. Thank you.
Thank you very much. That's much appreciated. A fascinating presentation with great resources, I think, for people there, and we'll make sure that we share those as well. So we're now moving on to another of our presentations with a regional perspective, and we have Dr. Olubusayo Akinola, who is a drug demand reduction expert for the Economic Community of West African States, ECOWAS, where she implements the project Support to ECOWAS Regional Action Plan on Illicit Drug Trafficking, Related Organised Crime and Drug Abuse in West Africa. She's been involved in several international and national projects on drug demand reduction, drug policy evaluation, and facilitates interagency collaboration and mechanisms for real-time information exchange systems amongst epidemiology focal points in West Africa. So I will hand over now to you. We can see your screen, but we can't see. There we go. Wonderful. Thank you very much.
Okay, thank you. Hello, everyone. My name is Olubusayo Akinola, as introduced, and I'll be talking briefly about the West African Epidemiology Network on Drug Use. Okay, this is the outline of my presentation. I'll be talking about the West African Epidemiology Network on Drug Use, overview of drug supply suppression and drug treatment demand in West Africa, and policy implication. The overall objective of the ECOWAS Regional Action Plan 2016 to 2020, which is currently being implemented, is to considerably reduce the incidence of drug trafficking, drug abuse, and related organized crime in the context of promoting peace, security, economic, and human development in ECOWAS member states. The regional action plan is articulated around 5 thematic areas, and one of the major thematic areas is to develop and maintain a sustainable system of relevant, valid, and reliable data on drug use, drug trafficking, and organized crime. SENDU was established in 2013 in collaboration with the World Health Organization, and was also established as part of the implementation of the 2008 to 2014 Regional Action Plan, which was adopted by ECOWAS heads of state and governments in December 2008. So we have 31 national focal points of SENDU, and they were nominated by ministers of health, justice, and interior in each ECOWAS member state and Mauritania. So for the focal points, we have 2 focal points per country, one representing the Ministry of Health and the other represents the Ministry of Justice or Interior, depending on where the Interministerial Drug Coordinating Committee is established in member states. And then we have only one representative from Mauritania. With the direct European Union financial support to the implementation of the ECOWAS Action Plan on Drugs, ECOWAS and UNODC conducted regional and national level training workshops to enhance the capacity of the WENDU focal point. There were some initial challenges in maintaining the established network, and the first was weak government institutions, fragile democratic processes, lack of political will. And hereby, with these, for example, we have nominations from the Ministers of Health and Justice, and when there's a change of political power, then there's a change of nomination. The new minister also brings in a new nomination, and the process starts all over again. We also had issues with data reliability and validity, and this was due to the fact that the focal points were actually manually imputing the data. So we had computational errors in the data that were sent. Then also we had non-availability of rehab centers and psychiatric institutions for treatment. For example, in Sierra Leone, we have only one psychiatric hospital, government-run psychiatric hospital, and one psychiatrist supported by a consultant from World Bank. And so these are some of the problems getting treatment data in our member states. And then another challenge we were faced with was lack of funding, resource limitation, and lack of basic office equipment to impute the data. And the last was the non-institutionalized epidemiology network in member states. In order to be able to address some of these challenges, national chapters of WENDU was established in 14 ECOWAS member states in collaboration with UNODC. And the last country we were not able to establish due to some political instability at that time, but the program is already on the pipeline. Based on the completion assessment targets for the questionnaire, the data completion rate of WENDU reports increased significantly. The ECOWAS also donated basic office equipment like computers, photocopiers, printers to enhance, and in some places data for internet connection to enhance the collection, collation, analysis, and dissemination of data. So the WENDU questionnaire, which was developed with the help of our consultant, Professor Obot, who is a consultant to ECOWAS on drug use prevention, treatment, and rehabilitation, was developed. This WENDU questionnaire captures two different types of data. The first is the extent of drug supply, and the second is the treatment data. So we have the data on distribution, level, and pattern of drug seizures were made available by the national focal points of WENDU, and these were analyzed in terms of quantities of drugs seized and the number of cases seized, cases of seizures. And the data also serves as a proxy indicator of trends and patterns of drug supply in West Africa. It was also important that we have data on the extent of drug supply due to the fact that initially prior to now, West Africa was looked at as a transit zone for the drugs that are going into the European countries. But with the upscale of our law enforcement agencies, most of these countries remain in the country and is being used by the populations of the country. The drug supply suppression, so this is the data for drug supply suppression overall, cannabis, pharmaceutical, opioid, CAT, which contains mainly catinone and cation, cocaine, heroin, methamphetamine, and key precursor chemicals for methamphetamine, such as ephedrine, were the main drugs that were seized in West Africa from 2018 to 2019. As we can see, cannabis continues to account for the largest quantities of drugs seized in West Africa from 2016 to 2019. We also have significant differences in cannabis seizures among the country. If you can see the Nigerian data by the left, the graph from 2016 to 2019, there was a 45% increase in seizure of cannabis in Nigeria. And the other graph is the trend in cannabis hashish seizures in West Africa, excluding Nigeria. And so in contrast to the increased seizure that we experienced in Nigeria, the trend for West Africa, excluding Nigeria, reflected a sharp decline in the quantities of cannabis that were seized. So in 2018 to 2019, cumulatively, about 200 tons of cannabis were seized in the region, where we compare that to the significant quantities that were seized in 2016 to 2017, which was about 871 tons of cannabis. Overall, a total of 1,076 tons of cannabis was seized in West Africa during the index period. And for opioid, the largest quantities of opioids reported to have been seized were of pharmaceutical opioids, and then this was followed by heroin. And we can see the data: 0.53 tons of heroin was reported to have been seized in the region, and then we can also see the trend in total heroin seizure per year in West Africa from 2014 to 2019. Then cocaine, a total of 2.83 tons of cocaine were reported to have been seized in the region. And we could see from the graph here that Senegal accounted for about 50% of the total quantities of cocaine seized during the reporting period, while in 2017, we can see the graph here that cocaine seizure, Cabo Verde reported the largest quantities of cocaine seized in 2017. And the graph on the left also indicates the trends in the total quantities of cocaine seized in West Africa from 2016 to 2019. We also have amphetamine type stimulants. The data on the ATS seizure reflected a downward trend. We could see 0.45 tons of methamphetamine was seized during the reporting period. We also had 3.7 tons of CAT, which is a plant-based psychoactive substance. It was seized from 2018 to 2019. And then we have 0.85 tons of ephedrine. Now, the precursor seizure data provides a typical illustration of clandestine manufacture in West Africa. We were also provided with data arrests due to drug-related offenses. And you can see from the region, a total of 95,919 arrests were made in West Africa from 2014 to 2019. Now, we also have the data on treatment demand in West Africa. The Wendy report captures the number and characteristics of people who use drugs that presented themselves for drug treatment rehabilitation services in the region. And this data, although we have different prevalent estimates that are limited and often not directly comparable, we consider treatment data as a proxy indicator to monitor the extent and patterns of drug use in the region. And so for the treatment data, this data revealed that only 53 persons per 1 million population accessed treatment in the region in the index period. And alcohol, as also said by Professor Obot and Dr. Nadine, alcohol was a commonly reported principal psychoactive substance used among people in treatment in West Africa. Though when we compare the different countries, we have higher proportions of people in treatment in Cabo Verde compared to other countries. It's also important to note that the proportion of treatment admissions for alcohol use disorder was higher in Cabo Verde, Ghana, and Guinea than the admissions for cannabis use disorder in the reporting period. Cannabis remains the main drug for which people undergo treatment in West Africa, and these account for over 55% of all treatment admissions from 2018 to 2019. It's important to note that 1 in 2 persons that access treatment from 2018 to 2019 reported cannabis as the primary drug used. And so we can see from the graph on the right, about 29 persons per 100,000 population in Gambia accessed treatments due to cannabis use disorders in 2019. Then opioids, the non-medical use of pharmaceuticals and synthetic opioids, as have been said by the earlier speakers, remains a major concern as West Africa continues to be a hub for diversion of illicit pharmaceuticals for illicit use. And heroin was the most commonly used opioid by treatment entrants, and these account for 12.7% of all treatment admissions from 2018 to 2019. And then Liberia recorded the highest number of people in treatment. So just in 2018, 15 persons per 100,000 population assessed treatment in 2018 due to heroin use disorder. So when we exclude Liberia from the graph, we can also see Guinea and Senegal reported high number of people in treatment due to heroin use disorder. The non-medical use of pharmaceutical opioids also appear to have grown considerably. In 2017, only 2 countries, that is Nigeria and Togo, cited tramadol as the principal drug used by the treatment entrants. And in 2019, 6 countries reported cited treatment entrants due to tramadol as the principal drug used by the treatment entrants. And in Liberia, we have about 5 persons per 100,000 population, and Sierra Leone with about 3 persons per 100,000 population, accounting for the highest number of people in treatment for tramadol use disorders in 2019. We also have the gender and substance use. The WENDU data reflected gender differential in substance use disorders among treatment entrants. 1 of 15 persons that assess treatment for cannabis use disorder is a woman. 1 of 5 persons and 1 of 6 persons that assess treatment for problems related to the use of alcohol and heroin respectively is a woman. And then we have equal proportion of men and women assess treatment for disorders related to the use of pharmaceuticals, and 1 of 9 persons that assess treatment due to cocaine use disorder is a woman. Now for the graph, this graph is showing the gender differences in primary substance used between 2018 to 2019. A higher proportion of men, that is 34% of men, assessed treatment due to cannabis use disorder, while women assessed treatment primarily due to problems related to alcohol use. And this accounts for 49% of the total population of women in treatment. Although alcohol accounted for the second substance, that's 31% commonly used by men in treatment from this graph, we have cocaine was the second substance recorded for women, and that's accounted for 20% of the total number of women in treatment. There was also a reduction in the gap when data on abuse of pharmaceuticals is concerned, and despite the differences in the gender by primary substance use for people in treatment, the observed differences could actually be attributed to lack of access to treatment services and higher stigma in women. In addition, women metabolize alcohol differently and achieve higher blood alcohol concentration than men, and are therefore more vulnerable to experience problems related to the use of alcohol. The age categories. The data indicates breakdown of treatment entrants by age ranging from 10 to 65 years, while 1 country reported 5 to 9 years in treatment, and this indicates increased risks for serious health consequences amongst this age group. Substance use disorder was, however, more prevalent among people aged 15 to 44 years from 2018 to 2019. The educational status of people in treatment. Majority of the clients that enter treatment for substance use disorder either had secondary education or never attended primary school. 1 of 2 persons who assessed treatment for SUDs had either only completed primary school or secondary education. This therefore underscores the need for evidence-based prevention intervention and policy framework to address substance use in primary and secondary schools in West Africa. The occupation of treatment entrants. Majority of the people that access treatment due to SUDs were unemployed, and a sizable proportion were students. The data also revealed that people who are unemployed were 2 times more likely to use drugs than those working in part-time or full-time job. Then we have HIV screening among treatment entrants. The number of ECOWAS member states reporting the data on HIV tests increased from 4 in 2015 to 11 in 2019. However, only 33% of these people in treatment know their HIV status, and we can see the trend in HIV reporting among people who access treatment for SUDs. It's also important to note that 1 in 5 persons that access treatment for drug use disorder in West Africa is high-risk drug user. The route of administration. The most common method of drug administration among people in treatment in West Africa is inhalation, and people who inject drugs also account for a modest proportion of treatment entrants in West Africa. Payment for SUD treatment services. The drug treatment services were substantially paid for by family and friends. However, in Cabo Verde, 70% of the people in treatment either had medical insurance or were catered for by the government. And so we had one of the high number of treatment entrants in the region was in Cabo Verde. Now, the sources of referral to treatment. People in treatment were most often referred by family and friends. However, there was an 12% increase in the number of countries that referred people into treatment from the judiciary, and this accounts for 75% of the countries in the region. The report suggests that several West African countries now provide option for referral into treatment and diversion away from criminal sanctions in minor cases involving the possession of drugs within the permissible threshold of quantities of controlled substances for personal use in each country. Policy implication. The WENDU data serves as an early warning for policymakers in the Ministries of Health, Justice, and Education by providing integrated characterization of drug use and emergence of new drug threats in the region. A significant finding of this report is that drug supply suppression efforts for drug control are more prominent in West Africa, while availability and access to treatment services for SUDs remains inadequate. The WENDU report also highlights the importance of age-appropriate, gender-sensitive drug use prevention and treatment policies in member states. The report identifies the need for school-based prevention program designed to bolster educational outcomes and strengthen youth resilience to drug use and its vulnerabilities. It further underscores the need for evidence-based prevention, treatment and care, rehabilitation and social integration policy framework to address substance use disorders in West Africa. Thank you.
Thank you very much, and perfectly on time. So you must have felt the end of your time coming. So that is much appreciated. An excellent presentation from the African region. And we're now moving over to some reflections on perspective of the Latin American and Caribbean region with Pernell, Clarke, who is a research specialist from the Inter-American Observatory on Drugs, which is part of the Inter-American Drug Abuse Control Commission, CICAD, within the Organization of American States. Previously, Mr. Clarke served as the director of the National Task Force on Crime Prevention, a research and development unit in the Attorney General's office in Barbados. And he spent time as the research and information officer with the National Council on Substance Abuse in Barbados, with responsibility for the National Drug Observatory. So if I could hand over to you now.
Good morning.
Thank you.
Hey, can you hear me?
Yes, we can.
Excellent. Thank you very much. I hope you can see my presentation. First of all, good afternoon to everyone on the other side of the Atlantic, and good morning to everyone here in the Americas. My name is Pernell Clarke, as was just introduced. I'm a research specialist with the Inter-American Drug Abuse Control Commission, or CICAD, as it is more commonly known. And this is part of the Organization of American States, a regional agency for the Americas. It actually it's a great pleasure to participate in this event. I'm seeing some faces that I've met before on the African continent, so it's a pleasure to see you guys again. And I'm happy to participate in this plenary on epidemiology and its role in drug demand reduction. And I want to thank the organizers, ISSUP, for inviting us to participate in this virtual event. So I only have 10 minutes to present, so I'm going to balance some of my slides. I'm going to run through some of them pretty quickly, not repeat a lot of what Professor Obot said earlier and what Nadine said earlier as well. but I'm going to give you an overview of how CICAD approaches drug epidemiology in Latin America and the Caribbean, and also show you some results. So let's go through a quick summary of what I intend to present. Very quickly, a basic information framework for demand reduction, some definitions. I'm not going to spend any time on the definitions. Professor Obot, I think, took care of those very nicely. Give you a brief introduction to CICAD's Inter-American Observatory on Drugs. That's the department where I work in CICAD, and how we work with our member states through national drug observatories. I'm also going to tell you about our Uniform Drug Use Data System, or CDUC, which is a system we use to collect information on drug use from several different populations. Share very briefly some of the results we've obtained over the years with you, and then leave you with some final thoughts and conclusions. Now, as I said, I'm going to go very quickly, but these slides are going to be made available to you, and feel free to access those slides for any further information that you will need. So this is just a framework to set up my presentation. I'm going to go pretty quickly. I'm sure all of the participants are aware of all of this. Basically, what is the information that we need to inform drug demand reduction? On the one hand, we of course need scientific theory and information on drug abuse prevention, of course, on the treatment of addiction. And on the other hand, we need the empirical data and other information to support what we do. This is where the epidemiology of drugs comes in. This is where situation and needs assessment in anticipation of an intervention come in. Of course, international agreements and the experiences of other countries is important, especially when it comes to regional groupings. And all of this needs to be underpinned by monitoring and evaluation and best practice. And each of these things require some data input. There's a prevention theory. We're talking about, in terms of the content of interventions, risk and protective factors, planned behavior, learning theory, social influence, life skills, etc. Methodology of implementation is very, very important. We need fidelity in the implementation of prevention programs. If you don't do it right, it's just not going to work. And then in terms of treatment, scientific knowledge on the disease. It is a disease known as addiction. Evidence-based treatment practice, treatment methods, comorbidities are very, very important. Medical issues, we heard some of that being presented just now by Dr. Akinola, and then other issues that are important to this population as well. Professor Obot did a very good introduction to epidemiology. I'm not going to spend too much time on this. All I want to say here is that this is a very important tool for the provision of data that is required for prevention and treatment. There's no question about it. And epidemiological studies help us to answer a number of questions that help us to develop public health responses to particular problems in our field, the field that we work in. Obviously, we're talking about drug use and drug abuse. So what are the questions that we need epidemiology to help us answer? These questions include, what is the extent of drug and alcohol use? For example, what's the prevalence, incidence, frequency of use? What is binge drinking like, etc.? Who are the persons? What's the profile of the individuals who are involved in not only drug use, but drug misuse, age, sex, etc.? What's the nature of drug use and abuse? What types of drugs are being used, the route of administration, how often they're being used, etc. Why has drug use occurred? We often turn to epidemiology to determine why certain behaviors are taking place. Are there changes in availability of drugs? Is pricing an issue? Are there socioeconomic factors that impact on drug use, whether it be increased urbanization, unemployment, maybe an economic recession, maybe a pandemic? What are the possible factors that cause persons to start using drugs and support the continued use? And then what are the consequences of this drug use, whether they be social, psychological, health-related, acute, chronic? And what are the social and other factors associated with this continued use? So those are the questions that we will use epidemiology to answer in our field. Just to pivot a little bit to tell you about how we approach epidemiology in the Americas. Most of you are aware, I think, of CICAD, the Inter-American Drug Abuse Control Commission, based here in Washington, D.C. Within CICAD, one of the departments is called the Inter-American Observatory on Drugs. This is where I work. And the OID was created in the year 2000. It's essentially the Statistics, Information, and Research Unit of CICAD. And we work with most of the countries in the Americas to varying degrees. Of course, there are some countries, USA, Canada, Chile, and a couple others that have the resources, both financial and human, to deal with this issue on their own. But there are several countries, which include most of South America, the Caribbean, and Central America, that benefit from the support that the OID provides. And our overall mission is to help member states to collect, generate the objective and reliable information and data that they need to better understand what the drug problem is, so that they can design and implement policies and programs to confront it in all its dimensions. So that's the role of the OID, or the Inter-American Observatory on Drugs. It's important at this stage, I think, to explain how we interact with our member states. So we work through similar entities at the national level, entities that we call National Drug Observatories. And the National Drug Observatory, just by way of defining what we mean when we say NDO, the National Drug Observatory essentially is the national agency that's responsible for providing factual, objective, reliable, and comparable information concerning drugs, drug addiction, and its consequences. The basic objective of a National Drug Observatory is to collect information. Let's get to the next slide. Right, to collect information and monitor the drug problem at the national level, analyze and interpret this information, and of course report it. Because if you are just collecting and analyzing the information and not reporting it, then you're wasting your time. So these are the three basic, what we call core functions of a National Drug Observatory. And of course, the National Drug Observatory is primarily for local audiences, for policymakers, for organizing drug-related services, for providing information of general interest to the public. But also, it's important, all of our member states and all of the countries, I think, participating in this activity have to collect and produce information needed to fulfill reporting obligations to either regional or international drug monitoring programs. So we all have to collect this information and report it both locally and internationally. How do we support national drug observatories in our member states? Through training and capacity building, providing technical support for research and other related projects, providing exposure to regional and international conferences and other training, horizontal cooperation where we have countries helping one another, and where it is available, we also provide funding for actual studies. Just some examples of some of the mechanisms that we've developed over the years. I'm just going to spend a little time on this because I think it's important to understand. So we have a number of mechanisms that we use in our member states. Drug information networks, early warning systems, treatment center data systems, and then the SENDU, Inter-American Drug Use Data Systems. The drug information network is similar to the epidemiology networks that previous speakers would have mentioned. Early warning systems are systems that are similar to drug information networks, but are designed to identify emerging threats so that countries can rapidly respond to them. We have a treatment center data system where we have a standard treatment form that's used in the Caribbean currently, and we have 11 of our 14 member states actually collecting data using that form. We have a publication that we're working on, and that will be coming out very soon. But what I want to focus on for the next minute or two is the Inter-American Drug Use Data System, what we call SENDU. And this is...
You've just got 2 minutes left.
Okay, thank you. We have a system of protocols that allows us to collect standard information from several different populations. students, whether they're in school, university students, emergency room patients, the general population, and others. So these are standard across the board. They're used by the majority of countries in our hemisphere, and they allow for standardization of basic indicators such as prevalence, perception of risk, access to drugs, etc. This report is available on our website. I'm going to put the URL at the end of my presentation so you can access it. But this is a report that we've done over the last, I would say, 10 years. Every 4 years, we do this report. It basically, we consolidate all of the information that we have from all of our member states into a single report and present on some of what is happening in terms of drug use in the Americas. Just to show you, because of the standardization of our protocols, we're able to compare countries across the board. This is an example of a particular chapter in the report. Is broken out by drug, of course, and in marijuana. In the marijuana chapter, we actually go into great detail about what is happening in marijuana across the hemisphere. We can put countries on the same graph because we're using the same comparative figures and methods. The gender gap is something that we've noticed is closing across many countries when we look at trends. Early initiation of marijuana use is a challenge for us. And then some of the trends we are seeing is that alcohol use seems to be on the decline. Tobacco indicators are on the decline. Marijuana prevalence among high school students, for example, is increasing or appears to be increasing. In the general population, is mixed. Indicators on cocaine continue to be high, but they're declining, increasing, or they're stable depending on the country you're looking at. And these are some of the trends that we've noticed in the hemisphere in 2019. But before I end, I want to mention a challenge that I'm sure everyone in this field is facing today. How do we carry out drug epidemiology during a pandemic? I mean, even before the pandemic, we had challenges: lack of finances, some were mentioned before, lack of human resources. These studies are not cheap, lack of expertise, etc. We've relied on well-defined populations, probability samples, paper-based, face-to-face or self-administered interviews, but we are now turning to using technology. And the challenge with internet surveys that we are facing, and we are working with some of our member states through this challenge, are poorly defined populations, convenient samples, and results that generally cannot be extrapolated to the general population. But we think that there's an avenue for internet surveys to be used in drug epidemiology once your population is clearly defined, and we're looking at how we can use this, for example, in the school setting, where we have some countries where many of the school systems have all of the students either with a laptop or some sort of tablet, and they're all internet connected. So we're going to be looking to see how we can use these things to continue our work on drug epidemiology in a pandemic. So in conclusion, as I said before, epidemiology is one of the key tools that we need to facilitate research, and it helps to inform drug demand reduction. And we need this information primarily for policy making, planning, implementing, as well as evaluating prevention and treatment responses. With that, I will leave you with, this is our website, www.ccad.oas.org. If you want to see that publication or any other publication that we have from our tools and our protocols, for example, we have standardized indicators for drug epidemiology networks. You're feel free to access those things. But I'm happy to be here, happy to share this information with you. I'm looking forward to answering any questions that you may have. Thank you all very much.
Thank you very much. That was excellent. Look at the observatory and how it works. We're now going to go into more detail around an actual country, and our next speaker is Dr. Roberto Canay. He is co-president of ISSUP Argentina, and previously he was a researcher on the psychiatric epidemiology program of CONICET, and director of the Addictions Observatory of the Buenos Aires city government. He's also held policy roles at SENDU in Argentina. So Dr. Canay, it's my pleasure to hand over to you.
I thank you, Joanna.
We just need your camera, if possible, Roberto.
Okay. Can you see my screen? Okay.
Yes, we can see the presentation. That's
okay.
Great.
Before I start, I want to apologize for my basic English. With this clarification, I can already say good morning and good afternoon for those who are in Africa, Europe, and Asia. It is my pleasure and an honor to participate in this event and share the panel with Pernell. I want to thank especially to ISSUP for the invitation. I also want to thank to the colleagues and friends from the African Union. Before talking about the situation of epidemiology in Latin America, I would like to make a brief reference about what we understand for scientific evidence and the international recommendations about it. Then I will briefly describe the progress in the region so far. And finally, I will share with you which are, from my perspective, the pending aspect of the systematization of epidemiological information and its relation with public policies and drugs prevention and treatment programs. Okay. When we talk about scientific evidence, it is important to highlight that we are talking about knowledge or information obtained through objective and validated methods, while evidence is information that exists regardless of the method by which it was obtained. As I just said, scientific evidence is information obtained through methods. That means it incorporates to assertion a degree of measurable certainty. Consequently, it places more weight on the methodology than on the person that is making the claim. Currently, governmental agencies, as well as the civil society, consider UNGA's 2016 documents, and particularly in our region, the CICAD's Hemispheric Plan of Action on Drugs. These international guidelines are regarded at least as mandate or guidelines to comply. Although I truly believe that little by little, these guidelines are being used for policy designs. The UNGA's 2016 document established some operational principles that drug policies should consider. For instance, the need to balance supply and demand reduction, the respect for human rights, the public health approach, and the gender perspective, and the evidence as the basis for policies. This is an important point. And also in 2016, the last CICAD's Hemispheric Plan of Action on Drugs was published. It emphasized the need to establish evidence-based drug demand reduction policies. It also stands out the public health approach, the need for a comprehensive approach, and the respect for human rights. Related to that, in the same CICAD's document, in the institutional strengthening section, one of the main objectives is establish our Australian National Observatory on Drugs. This is one important point. This is how we can have a National Observatory on Drugs in the majority of the countries in the region. As we can see from this graph, despite there exists still a gap regarding financial autonomy. There are 30 countries in the hemisphere that have the National Observatory. In this process, the Inter-American Observatory on Drugs has been crucial in order to achieve this progress. It has played a fundamental role supporting to create the national observatories. Pernell mentioned this point. The observatory of the Inter-American Observatory has also been fundamental in promoting and coordinate development, which allow the creation of comparable indicators and standardized data collection, method, and regular elaboration studies. In epidemiology, in order to have homogeneous and validated indicators, it is essential to have comparable studies. As we can see from this graph, the majority of observatories were established between 2000 and 2005, after the creation of the Inter-American Observatory on Drugs. Chile, for example, formalized its national observatory in 2000, Uruguay and Mexico in 2001, Costa Rica in 2002, and Argentina in 2005. I say that they formalized because before that, many countries in the region were doing studies and collection data. As we can appreciate from this slide, nowadays, 24 countries of the region includes their observatories in the National Strategy on Drugs. This information is from COPOLAT. These are the most common studies performed by any countries. Secondary school students, general population, patients in drug treatment centers, university studies. This is the more common and in our countries. The general population and the secondary school studies are performed every 2 years, generally. Nevertheless, not all the countries could maintain this regularity. Certainly, this is something for improve in this regard. As mentioned earlier, this allowed us to have comparable indicators between countries and then to make rational analysis and diagnosis. General population survey give us several common indicators. For example, as we can see in this graph, we have the past year prevalence of cocaine use for every country. I think Pernell shared some indicators from this document too. This is the same for secondary school students. But nowadays, and coming back to the importance to formulate evidence-based policies in all levels. It is necessary, it is increasingly necessary to have data at the local level. Strategies such as the epidemiological windows are a great tool to economically collect local data. In addition, they are easy to systematize. Therefore, the epidemiological window strategies allow us to obtain local information in a timely and costly way. Very often, these communities have indicators and reality which greatly differ from national ones. Local decision makers also need scientific evidence, so they do not plan blindly and to evaluate program and policies. A characteristic of this methodology is that recovers the experience and knowledge of the people from the community and from the key local institutions such as emergency rooms, treatment centers, and schools. In these slides, we can see how epidemiological indicators at national and local level may differ in the same country. In this example, which is from Argentina, we can appreciate the prevalence of the smokable cocaine used for general population at national level differ to the provincial level, and also that is this prevalence is much different for a specific social and economical vulnerable neighborhood. This is a social complexity in this neighborhood. For that reason, it is necessary to develop accessible system to give the possibility of think methodologically about this local reality. Consequently, it is important to have evidence not just at the national level, like countries, but also at the local level, provinces, cities, communities. This kind of information is also needed to drug prevention and treatment program level. At the program or local level, it's not necessary that all the technical workers or volunteers become researchers, but it is essential to give them the necessary tools to allow them to systematize our practices and reformulate it to their preventive and assistance programs. To conclude, it is important to that when we work with people, it is an ethical obligation to act and plan based on evidence. I want to end with a phrase from Spanish, Domingo Comas, that I met through Francisco Cuncille, who was one of the chief of the CICAD Observatory. And he said, the professional must know that in this historical moment, we have a clear notion of what constitutes scientific evidence. And so he or she must assume that being guided by scientific evidence, especially when working with people, is an unavoidable ethical obligation. This is for me an important point. Develop local structures for epidemiological data and the ethical component in all this development. Thank you. Thank you very much.
Thank you, Roberto. Very interesting presentation from the Argentine and perspective of that region. So we're now moving on to the last section of today's web session, and that is focusing on synchronizing global drug epidemiology data collection. I'm going to hand over, because as I said at the beginning, we were experiencing some significant technical difficulties, and the moderator for today's session is actually Dr. Reychad, Abdool, and who has been working tirelessly to connect whilst the session's been going on. So I'm so delighted that we could use you and your expertise for the end of this session. So I will hand over now to Dr. Abdool. Thank you very much for joining us.
Thank you very much indeed. Can you hear me?
We can.
All right, thank you very much indeed. My apologies, first of all, for being late on this call because we've been running through several difficulties. So without much ado, it is my pleasure now to go to the synchronizing the global drug epidemiology data collection. And we have two panelists to walk us through this presentation from UNODC, United Nations Office on Drugs and Crime. Therefore, it is my pleasure to introduce to you Ms. Chloé Carpentier. She is the Chief Drug Research Section at the Research Branch at UNODC. Ms. Carpentier has worked for over 25 years at the national, European, and global level in monitoring, analysis, and research on illicit drugs. And she is leading the drug research team at UNODC in Vienna. She oversees research activities in a number of areas related to drug markets, including their intersection with different aspects of development, such as health, economy, peace and security, governance, and the rule of law. In particular, she counts among her responsibilities the annual production of the flagship UNODC publication, the Annual Drug Report, which is, by the way, my Bible every year. So Ms. Carpentier started her career in 1994 at the French Observatory on Drugs and Drug Addiction, where she produced in 1995 the first French National Drug Report on drugs. She moved in 1998 to the EMCDDA, where she worked until 2014 on drug markets, drug relation crime, and drug supply reduction with a coordinator role from 2008. Ms. Carpentier holds an MSc in Demography, University Panthéon-Sorbonne in France, his postgraduate diploma in Epidemiology, University Pierre and Marie Curie in France also, and a postgraduate diploma in Evaluation and Public Health, University of Pierre Marie Curie, and an MA in Social Policy and Criminology, Open University in the UK in 2005. Ms. Carpentier, the floor is yours for the next 10 minutes. Thank you.
Hello, everyone. Thank you, Dr. Abdool, for your very kind introduction. I'm going to share my screen. So how do I show my screen now? Do you see something or not? Do you see my presentation?
Yeah, we can see your presentation.
Yes, please,
you see the full screen or not?
Yes.
Yes. Okay. So good afternoon again, and it's really a pleasure to be with you today. I will not present the data at global level on drug use and health consequences, because this is something that I presented in this conference in September, and I will focus today on a bit the conceptual framework and the kind of indicators that we use, without going too much into details because of the time limitations. So why drug epidemiology? Well, first is to support evidence-based responses to drug use. In particular, drug epidemiology serves to support the development of policies and programs, also interventions, data evidence-based, also to support the evaluation of the outcome and also of the impact of the policies and the programs that address drug use and health or social consequences, but also drug epidemiology by highlighting issues and trends, thereby support the allocation of resources to priority areas. And last but not least, drug use epidemiology contributes to the international monitoring on drugs and also to the policy debate at global level on the drug problem, providing, in fact, the data that will be used then to assess the extent to which global targets may have been reached or not. Now, also, drug epidemiology is to generate the reliable information that we need for policies and programs in identifying the existing drug use patterns, monitoring changes in extent and trends and patterns, and to determine and also to monitor health and social consequences of drug use. But many before me have mentioned this. Now, there is, in the recent years, the monitoring of the Sustainable Development Goals has brought to us another requirement for generating data, this time more specifically on drug treatment demand. It's called FREE, ensure healthy lives and promote well-being for all at all ages, and in particular target 3.5 about the strengthening of the prevention and the treatment of substance abuse, including narcotic drug abuse. And we have developed an indicator together with WHO, which includes basically it's a ratio between the number of people who are provided drug treatment services divided by the number of people in need of drug treatment, which we estimate as those suffering from drug use disorders. So this is an additional requirement at a global level. Now, but what is our conceptual framework? So our conceptual framework is based on the Lisbon Consensus. The Lisbon Consensus, which brought together a number of experts and international organizations from different global regions, and was endorsed by the member states at the Commission on Narcotic Drugs in 2000, so already 20 years ago, basically. So there was an agreement on the following set of key indicators that you see here on the slide. They are listed on the right. Indicator of drug use. And so we have the first one is about the extent of drug use, including the prevalence and the incidence in both in the general population and in the youth population, which mostly derived from population and school surveys. Others have mentioned that before me. Then we have an indicator related to high-risk drug use that is less defined in terms of, it can be regular drug users, those injecting drugs, others with drug use disorders, which is deriving from focused assessments or at least or indirect estimation methods. Population surveys are not the right tool for this. And then we have three indicators: treatment demand, or number of people entering or in drug treatment, the drug-related mortality, including HIV, but also hepatitis C, hepatitis B, tuberculosis, and mental health, and including morbidity and comorbidity, of course, and others, and drug-related mortality. And these three are derived mostly from data, from administrative data from registers. And all this has formed since 2000 then the core element of the global reporting on drug use and health consequences that we have at the UNODC and beyond. Now here, I don't want to comment on the slides, but I just want to show you very quickly how we have operationalized some of these indicators. So here you see in terms of the extent of drug use, we look mainly at the prevalence in the past year, in terms of number of people and also in terms of a proportion of the population between 15 and 60 years old. And here on this slide too, you see also the prevalence and number of people with drug use disorder. So this would be the high risk drug use for the second group. In terms of the past year prevalence, we also estimate by drug or by a group of drug wherever possible, or drug type. And then since 2 years, we have also started to estimate the prevalence in the last year of among young people, the 15-16. Why the 15-16? Because it's basically where there is the most information available around the globe, because of some school surveys that are based on this age in many countries now, and other surveys among youth. Then if we move to the high-risk drug use again, we also estimated the number of people with who inject drugs, the PWID, and among them we estimate the prevalence of those who inject drugs who are also living with HIV. And continuing on morbidity, there's also an estimate of the people who inject drugs who are living with hepatitis B and hepatitis C. All this, of course, is by country, wherever data are available, and also by sub-region and by region. And then we also have data on drug treatment demand. Here we can see people entering drug treatment by primary drug of concern, basically by the drug that motivated the demand for treatment, but many of them may be polydrug users. So it's just to give an example of how we have operationalized up to now. And this one is about drug-related death, and this is perhaps the weakest area where a number of methodological issues really need still to be resolved, to estimate routinely in a good way the number of both direct and indirect drug-related death at a global level. Here we need really to acknowledge that drug-related death, even if we only look at the direct ones, and by the direct ones I mean mainly the overdoses and what we call those related to drug use disorders, remain poorly documented in a large number of countries. So here even we don't have direct data for the moment, but we are discussing with WHO and see how we can together produce something at a global level that would be routinely acceptable. Then here you can see the different dimensions of drug use in the middle of the pyramid that correspond to the main key indicators of drug use. And on the left side, you can see the corresponding sources of information, while on the right side, we can see the interventions that address these different dimensions of drug use. So it's a sort of slide to put everything together. And on the top of the pyramid, you see in the part colored in red, what we call the non-drug users. These non-drug users are those that appear in registers, in treatment, or in mortality registers, etc. So these are the knowns, and the rest are the unknown, basically. And there's only the tip of the iceberg, of course. But what the key indicators do not capture well are the emerging drugs and also the emerging or changing patterns of drug use, as well as recent trends. So for these, we use additional sources of information. But here, I think what's important to highlight is that there has been no consensus at global level on standard indicators or on measures. So as is mentioned in the slide you see here, we use in our analysis some case reporting from emergency room visits or outreach or drop-in centers. Also, we look sometimes at the samples of drugs that are being analyzed by forensic services to see what are the drugs that are appearing or disappearing from the market, etc. And one other source of information, of data that may contribute greatly to drug epidemiology, at least at global level in the regions, is what comes from wastewater analysis, which is basically the analysis of the metabolites of different drugs that is found in wastewater. It doesn't allow us to estimate the number of people using drugs, but it allows us to estimate the amount of drugs used, so the consumption. And we have found that for some areas it's very telling, because it's a better indicator. In fact, it can be an indicator of harm rather than anything else. And I give an example is Australia. In Australia, the prevalence of drug use, cocaine use, is extremely high, the highest in the world. But when we look at consumption from wastewater analysis, we see that the level per inhabitant twice lower than in Western Europe. So the problem is very high, but in fact, consumption is very low. So in terms of harm, it might be also relatively low. So it's just to give an example. And one area that is now coming a lot more in terms of the global debate on the drug problem is the issue of vulnerable populations and drug use among vulnerable populations, especially since the UNGAS 2016, so the United Nations General Assembly on Special Assembly on the issue of drug. And here we see I've listed a number of population groups that may be especially impacted by socioeconomic inequalities resulting from drug use disorders, but also that may be more inclined to be affected by drug use disorders because of their socioeconomic disadvantage. Here also, there is no international consensus on vulnerable populations, nor on how to monitor drug use among these groups. But this is something that is increasingly being mentioned in the global debate. And here's an example of what we did some years ago on drug use in prison. It was an ad hoc review, mostly based on literature, both from scientific published literature and grey literature, as you have to understand that most of the member states don't report on these issues or on this specific group of populations, even if we request them to submit data routinely through the annual report questionnaire. And my colleague Enrico Bisogno, who is the next speaker after me, will be able to tell you a bit more about that. But even if we request, many of these areas member states don't report. And my last slide is to inform you about the interagency technical working group on drug epidemiology that we established in 2016 together with the World Health Organization, and which includes the African Union, the MCDDA, and also the Organization of American States. It was established to strengthen our strategic partnerships and also to ensure better coordination and harmonization of efforts in drug epidemiology. So the idea is really to identify major gaps and challenges in producing global and regional estimates. Also, we have used the group, and it proved to be very successful in discussing the different approaches, the gaps in the data, the challenges for reporting on the SDG target 3.5, which is the indicator of treatment coverage I mentioned before. And so this is together with the group that we also developed the indicator. And the group is really key for identifying key priorities for collaboration, and then decide between ourselves what are the responsibilities. The last issue we worked on was this indicator 3.541 on treatment coverage. So I will stop here, and I thank you for your listening. And I'm sure you will get perhaps more details on our global data collection with Enrico Bisogno, my colleague, who will speak after me. Thank you very much.
Thank you very much indeed, Ms. Carpentier. So now we shall invite Mr. Dr. Enrico Bisogno. He's the Chief Data Development and Dissemination Unit at UNODC in Vienna. He is responsible for developing and implementing statistical programs including activities relevant to relevant indicators for the UN Sustainable Development Goals. He recently led the finalization of the International Classification of Crime for Statistical Purposes and the Manual on Corruption Surveys. Dr. Bisogno has previously worked with the National Statistical Office of Italy, the UN Economic Commission for Europe, and the UN Economic and Social Commission for Asia and the Pacific. And he's developed extensive experience in many areas of social and population statistics, including gender statistics. An Italian national, Dr. Bisogno holds a PhD in demography from the University of Rome and a master in statistics and demography from the University of Padua in Italy. Dr. Bisogno, you have 10 minutes, please. Thank you.
Hello, I hope you can hear me and you can see my presentation. Is that?
Yes. Yes, we can.
Okay, it's okay. Can I go? You can see me.
Yes, we can. We can.
Okay. Thanks. I see that we are a bit late, and but still see that there is a high number of attendees. So I'm sure that they are all very much interested in the ARQ and the data collection on drugs. I just wanted to share with you our recent experience on this instrument that went through a comprehensive review process starting in 2017. You know, this is which as a result of a decision by the Commission of Narcotic Drugs. So here you can see the extensive consultation process we went through to first take stock of the previous, actually is still the current ARQ, and consult with a high number of stakeholders to have a better tool to monitor drug issues, drug problems across the world. We are now at the stage where we are developing the actual questionnaire and a new data collection platform. And in next year, spring 2021, fingers crossed, we will launch the new ARQ. Okay, how will it look like? We have structured the new ARQ in a series of modules. Actually, there will be 27 modules, which we can see broadly defined in between demand, supply, and cross-cutting issues. And there will be a number of modules, so which means a number of data that will be collected annually on an annual basis, while some others, many more actually, will be collected on a rotating basis. This is mainly for two reasons. One is that there's a certain number of topics that are issues that don't change so rapidly. So that collecting information every 2 or 3 years will be enough for sufficient from an international global perspective. But also this also was an option to reduce the burden on member states, the reporting burden on member states. So this an important distinction we introduced in the new RQ is that we have differentiated the type of information we will collect, we will ask for, distinguishing between basic information, which is mostly qualitative in nature, from statistical, really truly statistical data, and then some more in-depth information or more demanding data that we assume will be only for probably especially at the start only a selected number of countries that will be able to provide. But the idea of also this differentiating this type of information is really to make a tool that can be as flexible as possible, so that all countries from the most advanced to the less developed can still provide some useful information to understand how drug issues are evolving in the country. So, for example, yeah, qualitative questions where the opinion of experts will be asked. We firmly hope that the most, if not all, countries will be able to provide. You can see the number. So we also took a lot, great care to really reduce as much as possible. Again, as I said, the number of questions. So you can see also, from this chart, we tried really to have only the really core questions asked on an annual basis. I just wanted to, we know that we are talking about drug epidemiology, but just to give you a flavor again of this tool, which you have seen will be quite comprehensive. It's quite comprehensive. There are two. Just wanted to draw your attention on two topics, which are we believe which have been treated in a different, novel way. We believe. Really, one is to collect comprehensive information on the legislative, institutional policy framework at country level, so that we really can put the numbers in the framework where they apply. So again, what is the situation in terms of the legal framework, the mechanism to place substances under control, and so on, so that we can. And this information, of course, is not collected on annual basis because it doesn't change so often, but this is the information that is needed to understand also the actual data, including those on epidemiology. And then another aspect where we really put a lot of attention is about the criminal justice response to drugs, which is not only, if we say criminal justice, is not only about law enforcement, but about supply or about people arrested. But also, we really try to have again, an overall holistic view on what all the ways the criminal justice system enters into contact with drug trafficking, also drug possession or use. For example, with information on alternative measures to conviction or to punishment, or custodial alternative to custodial sentences, or an in-depth module on drugs in prisons. There are also there is a series of new other modules and new other topics, which is listed. You can see them here. Then, of course, there is much more information also available on our website. And another element where we also put a lot of attention is really how to improve the ARQ system. So, which will be based on a network of national focal points, and we hope as much as possible that the focal points would be the same that are, for example, other regional organizations are using, whether it's in Europe or the ones that we mentioned earlier on in Western Africa or in Latin America for CICAD. It will be a web-based data collection, and again, we really are striving to collaborate, to coordinate with regional organizations so that we can conduct this data collection in very close coordination with them, with the principle that the same figure should not be asked twice to a member state. We really would like to implement this principle. I just wanted to show now. This was just to give you an idea of what will be the new data collection system. Chloé has already illustrated what will be the contents of this data collection in terms of drug epidemiology indicators. Just wanted to give you again a small flavor, for example, about the data availability, current data availability according to the ARQ for some key epidemiologic indicators. This, of course, refers to data that we receive, This doesn't mean that these data don't exist. For example, from the presentation from Dr. Akinola in ECOWAS, I could already see that some data that they have, we don't have here in Vienna at the UNODC. So for sure, there is also an issue of communication. But as you can see from this chart here, in these two charts which I'm showing the availability of key drug prevalence in total population and persons with drug use disorders. When I say availability, means the percentage of countries with at least one data point in the last 3 years. And you can see, of course, it can be quite disappointing. But globally, we have only less than 20% of countries that are able to produce at least one data point in 3 years, one new data point. And the percentages for Africa are particularly low. I'm going very quick to the end. When we go towards, we consider two other data indicators that are more based on administrative system rather than surveys or indirect systems. We see the interest that there are regions like Europe or even the Americas, Asia, that of course have a much better coverage, while in Africa is not yet the case. So even for data based on administrative, usually administrative sources. This is the last slide. We know that, of course, data can be more available first if they are produced at local, at country level. But we are trying to do our best to elicit, to collect all the information that is available. This, of course, we'll have to do a lot of communication with coordination on with regional organizations. But we also put some additional efforts in the way we are designing the new data instrument. So you can see here, so to provide better definitions, to be to give the possibility to provide multiple types of data, so that they can be surveys, they can be indirect methods, and so on. The possibility to provide qualitative information, and last, the possibility to provide to give us additional studies or data that maybe do not fit exactly what is requested in the RQ, but still will provide information that is useful for, again, to understand what's the trends in the country. I will stop here, and of course, we'll always be happy to answer to any question now or in writing that you might ask us. Thank you so much. Over to you.
Thank you very much indeed, Dr. Bisogno. And in the meantime, the team in London has received a number of questions, which they have now synthesized into 3 key ones. The first one goes to Professor Obot. Could you give us an indication as to how much data there are on men versus women, and what challenges have you seen in collecting data by gender? Isidore, the floor.
Okay, can you hear me now? Hello?
Yes, we can. Yes, we can.
Okay. Yeah. Well, I think there are certainly some issues around data collection when we look at gender differences. It's in some instances, it's difficult to reach women in some parts of, for example, Nigeria. So access can be a problem. So you try to have a representative sample, and at the end of it, you end up with much fewer women than men. It's usually because of poor access. And the access are cultural in nature, where you cannot talk to a woman alone, and you don't want somebody to be there with you when you are talking to her, trying to elicit responses. So you end up not having enough women. In the national survey, it was an issue, but not a big issue. We had a good representation of women, the national survey on drug use in Nigeria that I talked about earlier. So yeah, I want to say that you're making a good point about gender. Gender is a big thing, and we have to find a way to get women into our samples.
Thank you very much indeed, Professor Isidore. Now we move to the second question, which is addressed to Dr. Akinola. And the question is, could you please demonstrate where practitioners can access information, including an African-wide report, and what resources you would recommend to help listeners use these data to influence their practice? Dr. Akinola.
Okay, thank you everyone for the information, the data, like I also described earlier. We have two data sources, one from the health for the treatment data, and the other data source is for the supply data. For this data that has been collected by the member states, currently we have the 2014-2017 data that is already published. Once the data has been validated by the member states, it goes through a process. After validation, we have the heads of states and governments endorsing the data before it's been published. So currently we have the 2014-2017 data on the ECOWAS website, www.ecowas.int. So this data, this can be accessed from the website. And then the 2018-2019 data, we're waiting for the final level of validation and then move to the heads of state and government endorsing such data before it can finally be published. Thank you.
Thank you very much. And the third question is addressed to both Pernell Clarke and Ms. Carpentier. So the question is, how do you define drugs in your work at CICAD and UNODC, and where does tobacco and alcohol fit in this definition? So let's start with you, Pernell.
Okay, thank you very much. Very good question. So for us in the OID and at CICAD, while our mandate speaks very specifically to drugs, meaning the illegal type of drugs, in our data collection activities, we include both alcohol and tobacco. It wouldn't make sense to collect data on drugs without collecting data on legal substances as well. So in all of our research, in all of our epidemiological networks, in all of the work that we do, we include alcohol and tobacco as part of our group of substances known as drugs. So I hope that answers that question.
If not, then Ms. Carpentier will complete.
Yes, so for us, basically, drug use is defined as the use of controlled psychoactive substances for non-medical and non-scientific purposes, unless otherwise specified. So this is really the definition in the World Drug Report that has been negotiated here with different parts of the House. So I'm not allowed to say differently. But basically, no, alcohol is not included in the range of psychoactive substances that we include under the terms drug. We also use NPS. The NPS are the new psychoactive substances. These are those that are not controlled under the conventions, basically. But over the years, some have been controlled also lately. So there is a tricky exercise of following up what's happening with substances independently of their legal status. Because, for example, methadone some time ago was an NPS, and it was used as a substitute of MDMA when there was a shortage in the years 2009, 10, etc., because of the shortage of the precursor. And then when MDMA was again available, people go back to MDMA because they prefer ecstasy. And in the meantime, methadone has been controlled. So now it's drugs and it's not NPS, but we still need to try to find a way how to continue to monitor this in a sort of continuous way. Yeah. This is one of the challenges at the global level, I would say. I hope this is satisfactory answer. So in our reports, we have been trying to really align the language. We talk about drugs and not illicit drugs. This is very important because a drug is not illicit. It can be controlled or not. What is illicit is maybe the behavior. Well, maybe the use may be illicit in some countries, but most is not, use is not illicit, is the possession, etc. And then we talk about NPS and we talk about drug use in general. And when we talk about drugs, including controlled medicines that may be misused, then we talk about non-medical use. So we also cover the non-medical use of prescription drugs. Thank you.
Thank you very much indeed, Ms. Carpentier. And with this, we bring this session to a close. Thank you to all of our eminent panelists and to all of those who have been listening to us. And also thank you from my part to the ISSUP team for bringing me on board, because it has been a struggle. Thank you. And thank you to the ISSUP and the INL and AU and CICAD for organizing this session. With this, we close this session now. Thank you very much indeed.
Thank you.
Bye-bye.